Okay, now that you know what the orbit's supposed to look like on a CT scan with normal anatomy, let's go over a couple examples of fractures. First up, you'll notice that this video is a little bit cut off at the top for patient anonymity. However, I did want to show you that right away we'll be using CT scans with 2mm cuts. Although this isn't ideal, I wanted to show you this scan to show you what an obvious fracture would look like first. So, pulling up our coronal scan, as we begin to go more posterior, we start off by looking at our orbital rims, including the superior orbital rims, the lateral orbital rims, and the inferior orbital rim. Starting on the right side, we don't see any obvious fractures of the inferior and lateral or of the superior. On the left side, once again, the inferior seems okay, the lateral seems okay, as well as the superior. Next, let's look at our medial walls and floors. The medial wall here seems to be okay. It doesn't show any obvious breaks or signs of a blowout fracture. The same applies for the floor on the right side. In addition, as we scroll through on the right side, we do not see any other defects on the superior or lateral sides. Switching over to the left side now, looking at our floor, as we scroll back, we see a break right here. With any orbital floor fracture, you always want to assess for herniation of fat contents, extraocular muscles, and orbital contents. As I mentioned before, sometimes it's useful to use other windows to assess these muscles. But first, let's just look at the fracture itself. We can see the orbital floor has a relatively large break in it from here to here, and it's a blowout fracture as the floor has been blown out of the orbit and is projected downwards. This is an example of a very obvious orbital floor fracture. Let's look at it from a different view. If we pull up our sagittal view next, and we scroll through, we can tell that this is the unaffected right eye. The sinuses are clear. We do not see any break in the orbital floor or herniation of any contents. However, as we scroll to the other side, here you can see a break in the floor, herniation of contents, and as you can tell, once again, it's a very large fracture of the left orbital floor. Although this is obvious from a coronal and sagittal point of view, as you can tell on an axial scan, when initially scrolling up, it might not be that obvious to see where exactly this fracture is. That's why, as usual, it's always good to pull up multiple views, use a 3D cursor, and it will show where this large gap in the floor is. But once again, as I'm sure you can appreciate, it's much easier to see on a coronal and sagittal view compared to an axial view. The last thing we want to assess for is entrapment. Now, remember, when it comes to orbital fractures, the larger the fracture, the less likely there is to be entrapment. And this makes sense because if you have a large orbital floor fracture, it's very difficult for the muscle to become entrapped in that defect because it's so large. As you can tell, you can see faint outlines of the muscles here in the bone view. But if we switch to another view, for example, abdomen, pelvis, or head and neck, it becomes much easier to see these muscles. Here we can see our fractured bone, and we can see the inferior rectus right here. Although it has been downwardly displaced, there are no signs of entrapment. Just to show you what it would look like on a normal side, on the right side, you always want to see your bone with no breaks or fractures, and a smooth muscle, usually oval in shape above the bone, with no entrapped portions in between. Let's take a look at another example. Starting on the right side, we seem to see a discontinuity in the right inferior orbital rim and floor, actually becoming quite large. Once again, it's always easy to look at the sinuses to see if there's any blood in the sinus, as well as compare to the contralateral side, to always look at what a normal side should look like if you suspect no fractures on the contralateral side. As you can tell here, on the left side we have a nice smooth orbital floor, and here we have a large defect representing a large orbital floor fracture. In addition, if you look at the right side, as we go more posteriorly, you can see on the medial wall there also seems to be a fracture. Compared to this smooth outline here, we can see a jagged, bumpy, often broken line here. This makes sense as, in addition to the orbital floor, the medial wall, especially the lamina propria, is extremely vulnerable to fracture. When you often hear people talk about blowout fractures, they are simply mentioning the fact that the walls of the orbit are blown outwards or away from the orbit after a force is subjected to them. And this is what we see. We see a blowout fracture of the orbital floor and of the medial wall. Now, you always want to look at things in different views, and when it comes to the orbit, it's very simple to think of which views will show which fractures in the best light. For example, if you think about it, an orbital floor fracture is best seen in a coronal or sagittal view. This is because the orbital floor itself is positioned in the axial plane. This is why it's more difficult to see an orbital floor fracture in the axial view. Similarly, a medial wall fracture is best seen in a coronal or axial view because the medial wall is positioned in a sagittal plane. So let's say we wanted to see this medial fracture better. We'd pull up two views. Once we have our axial view, we'll take a look at the same area on an axial scan. As you can see, comparing with the contralateral side, you see multiple comminuted fractures of the medial wall of the orbit, as well as the hemosinus of the ethmoid sinuses here, compared to the clear sinuses on the other side. Now let's say we wanted to see the orbital floor fracture in a second view. We could pull up our sagittal scan. We see a large orbital floor fracture again. If you wanted to confirm you're on the right side, you can just use your cursor. In addition, as I mentioned before, when looking at fluid in the sinus, it's always easy to tell the difference between fluid and pathology such as a cyst. As you can see here, the fluid has all gone to the right side of the sinus on the sagittal scan. This is because, as you can imagine, for the CT scan, the patient is lying flat with their head down. So if this side is down and this side is up, the fluid will naturally fall with gravity and fall to the bottom of the sinus on this side. Now that we've diagnosed a right orbital floor fracture and a right medial wall fracture, you always want to check for signs of entrapment. Let's focus on our coronal scan, and once again let's switch our window. Here you can see the area of our orbital floor fracture, but it's difficult to discern the difference between where exactly the muscle is, what is a hematoma, what is blood, and what is the muscle. This scan would be concerning for signs of entrapment, especially since the muscle seems to be a little bit more radiopaque in this area. Therefore, although this is a large orbital floor fracture, we cannot rule out radiographic signs of entrapment, and you'd want to make sure to correlate clinically. Let's look at one more example. In this scan, I want you to focus on the left side. As you start to see the rims come into focus, you can see this very radiopaque structure on the bottom. We haven't really addressed this in the course thus far, but when looking at scans, it's always important to look for previous surgeries and previous fractures that may have occurred. The most radiopaque thing you can see on a CT scan is metal, and that's what we're seeing here at the inferior orbital rim. This indicates previous fractures and surgery of the face. You can also see it here. This one is spanning the ZF suture, indicating likely a previous left ZMC fracture, but we'll go into that in more detail in the ZMC module. As we continue to scroll, after noting the metal plate, we can see a break in the supraorbital rim. This indicates a left supraorbital rim fracture, or an orbital roof fracture. As we continue to scroll, on the left side, we don't see any other obvious signs of fracture, but it's always important to look in all three views. As we pull up our sagittal view next, we take a look at this side, and once again, we're able to easily visualize the fracture in the supraorbital rim. To make it even clearer, you can see in the bone view how much easier it is to see. In addition, in the sagittal plane, you can see the small metal screws and a plate that's here on the infraorbital bar. Once again, scrolling through, there are no obvious signs of fractures, other than the one we saw at the orbital roof. Let's now look at our axial view. As we look at the left side on the axial view, there is one other area that is not obvious on the other two views. Here we can see our supraorbital fracture, our orbital roof fracture, that actually extends into the frontal sinus here. But in addition, if you scroll down, you can actually see a small fracture here in the lateral orbital wall. Remember, on our axial view, although it is not good for visualizing floor fractures, it's very good for medial and lateral wall fractures, as shown by this example. You can see this very, very small fracture in the lateral wall that wasn't able to be appreciated on our coronal or sagittal views. This further emphasizes the point that whenever looking at a facial trauma scan, you want to look at all three views, go systematically through every view, and look at both sides from front to back all the way through the scan. You'll pick up new fractures in different views, especially small and subtle ones, and that'll separate you from the other residents. So at this point, we'd be able to diagnose on this scan a patient with a left orbital roof fracture and a left lateral wall fracture, as well as plates and screws indicating previous surgery. The last thing I'd like to mention when it comes to orbital fractures is that when you review your orbital anatomy, you'll remember that the bony orbit is composed of 7 different bones. However, when describing fractures of the orbit, you don't necessarily need to comment on which bone is fractured, rather than which area of the orbit is fractured. For example, as shown here, the medial wall of the orbit is composed of several different bones, including the frontal process of the maxillary bone, the lacrimal bone, the ethmoid bone, the sphenoid bone, the frontal bone, and even the palatine bone. However, when describing a fracture of the medial wall, you would not describe, for example, there is a fracture of the right lacrimal bone. Instead, you would say there's a fracture of the right medial orbital wall. This same principle applies to the rest of the orbit. As you head into your practice scans of the orbit, make sure you mention fractures of the orbit with their correct terminology. That is, the inferior orbital rim, the lateral orbital rim, superior orbital rim, the medial wall, the orbital floor, the lateral wall. Describing the area of the fracture is more useful than describing the actual bone itself. Also, don't forget to include an evaluation of all nasal bones when doing your practice scans, as you will be asked to comment on the presence or absence of nasal bone fractures going forward.